Welcome, everyone. I'm Noah Reed, Vice President of Sales and Marketing for the Dutch Test. Thank you all for joining us for this Dutch webinar featuring our very own Director of Clinical Education, Dr. Debbie Rice. Today, Dr. Rice will present on menopause and hormone replacement therapy. This presentation will include a review of Dutch case studies that show hormone testing can benefit patients experiencing menopause. Dr. Rice will show you how to recognize the hormone patterns of menopause on the Dutch test, and she'll review the benefits and the risks of HRT for this patient population. Before we begin, I want to remind you that there are just 2 episodes left of the special edition of the Dutch podcast. The Dutch Summer School series is available to stream now wherever you get your podcasts. Each week in summer school, Dutch Chief Medical Officer Dr. Jacqueline Smeaton sits down with one of our wonderful clinical educators to talk about hormones and review Dutch case studies. Catch up on previous episodes, including the most recent episode on estrogen metabolism and breast cancer risk. You'll also have a front row seat for in-depth discussions on hormone topics such as estrogen dominance, flat cortisol curves, intermittent fasting, and PCOS. And if you love listening to the Dutch podcast, don't forget to rate, review, and subscribe to get the latest updates on season 3 that will be dropping next month. And as always, we would like to extend an invitation to all of you that are joining us for the first time or haven't yet signed up to become a provider. There are many perks to being a registered Dutch provider. Dutch providers have access to exclusive educational resources like the Mastering Functional Hormone Testing course and the Dutch Interpretive Guide, plus one-on-one consultations with Dutch clinical educators and opportunities to learn alongside other new Dutch providers in group mentorship sessions. You can find the links to these resources in the Dutch provider portal. Make sure you click on the link in the chat to become a provider today. Now let's introduce today's speaker. Dr. Rice is the Director of Clinical Education for Precision Analytical and practices part-time as a naturopathic doctor, where she focuses on care on pediatric, hormone, thyroid, and adrenal health. She has had experience working with communities in need, both in the United States and internationally. Her training is primarily in women's health, pediatric care, hormone therapy, and hormone function, as well as complementary adjunct care. Dr. Rice uses diet and lifestyle, botanical medicine, and conventional approaches to maximize care for her patients. Thank you for being here with us today, Dr. Rice. We're ready when you are.
Thank you so much for having me. I am excited to be here today to chat through the Dutch test and HRT. So what we're looking at today is menopause and HRT and how hormone testing can help. So when we talk about HRT, we're talking about hormone replacement therapy. Now, I always have to remind you guys that this information has not been evaluated by the Food and Drug Administration. So be careful with the information that you have. This is not medical advice, and you should use your own schooling and understanding of medicine and your experience to use this information to your advantage. So the goals for today are to understand menopause and perimenopause and the major hormones involved, define hormone replacement therapy and options for replacement, and to familiarize ourselves with testing options and how testing can enhance evaluation and treatment. So that's going to be the biggest one that we look at. So first, we want to kind of understand what menopause is, right? Some of you people are like, oh, yeah, I know. But we want to understand that menopause occurs around ages 45 to 55 years old in females. And we want to understand that menopause is a multi-system effect. So this affects your cardiovascular system, your neurological system, your digestive system, musculoskeletal and bone health, can affect your hair, skin, nails, and your hormones, right? Obviously, hormones are definitely affected through menopause. The stages of menstruation, we have our cycling female. This is generally someone who cycles every 28 to 35 days with a 3 to 7 day bleed. When we hit that perimenopause stage, this is where we start to have irregularities with our cycling, right? It can be sooner than 28 days, later than 35 days, bleeding more frequently, bleeding less than 3 days, or more than 7 days. And the volume of blood may be a lot less or a lot more. Essentially, what that means is your cycles become a mess and they can be really unpredictable. We hit menopause when we have had no bleeding for 12 consecutive months. So the important part of that is, you're on the countdown, 365 days, you haven't had a cycle for 322, and then you spot or you bleed, guess what? The clock starts over. So you have to have no bleeding for 12 consecutive months to be considered menopause. Once you are in menopause, you can hear that being like, I am in menopause or I am postmenopausal. The phases of perimenopause, which lead you into menopause, can include like the very early perimenopause. And this is when your cycles can still be regular, but things just feel different, right? Like your cycles feel different, or your mood feels different around your cycle, where you can just feel a shift in your cycles, even if they're coming every 28 to 35 days. The next stage is early menopause transition. So this is where you get the onset of those irregular periods. Then you transition into late menopause transition. So this is from the first cycle of more than 60 days, right? So you skipped a period for more than 60 days. Then we get into late perimenopause. This is the 12 months from your final period. So that's when you've had that 365-day mark of no cycles. And then menopause is the life phase that begins once you have reached that 365-day mark. So one of the things that I want to show here is that menopause time can be anywhere between 3 to 4 years, and the onset of that can lead into like the 2 to 5 year mark of where you're in that very early perimenopause transition. So when we're talking about menopause and perimenopause, people will say, maybe about 4 to 5 years. But when we look at the true perimenopause transition, it can be anywhere from, 5 to 10, 9 or 10 years. Just remember that as you're considering like where you're at, if you're perimenopause or menopausal, when you started to notice any kind of shifts in how that cycle is being affected for you. So if you guys know me, you guys know I love Laura Briden. I feel like a lot of people are fans of Laura Briden. She has a wonderful book called The Hormone Repair Manual, where she talks about perimenopause and transition from perimenopause to menopause. What I like about this picture here is this shows that that kickstart of estrogen and progesterone, what happens when we're cycling, and then what happens as we transition into perimenopause and menopause. So estradiol is the hormone that we think of when we think about females, right? It has significant variability at the beginning and the end of menstruation. So at menarche, the beginning part of our menstruation, and then again at menopause. So what you'll see is this, estrogen starts to kind of sputter up to try to get that signaling going. And it needs to have consistent and predictable signals so that progesterone can come in. Once estradiol is consistent, it can appropriately signal for ovulation. Once we have ovulation, those progesterone levels can rise for ovulation for that month. Perimenopause begins greater variability of estradiol signaling. So this is where that brain to ovarian signaling starts to get a little bit more inconsistent, and you have a lot more variability. So when we see this, the estradiol signaling continues to be pretty erratic until it falls off and wanes into very low. The hormones involved in menopause, especially the ones that we are going to focus on today, estrogen, progesterone, testosterone, cortisol, and DHEA. I know a lot of people think like cortisol and DHEA, those aren't sex hormones, which is correct. But our cortisol and DHEA, our adrenal function, are also huge considerations when we're looking at menopause and how well our bodies are dealing with stress and what the overall hormone picture can look like. We can do estrogen, progesterone, testosterone, cortisol, DHEA testing in serum, which is blood testing, and in urine. The other key hormones that we look at are FSH and LH, and these are best tested in serum. So for today, we're really going to hone in on estrogen, progesterone, and testosterone. So I would like to look at, this is what we call a steroid hormone pathway. When we're looking at the steroid hormone pathway, the reason why this is important is because cholesterol is the precursor to all steroid hormones, right? So these are your sex hormones and your cortisol. The one thing that I want to note here is that estrogens are the last stop on the steroid pathway. So when we look at this, a lot of the hormones end up converting, and we like when we look at our progesterone, we look at our testosterone, we can see that those androgens, the DHEA, testosterone, end up converting into estrogen, and then estrogen has to be detoxified and metabolized out of the body. That's why I say it's the last stop on the steroid pathway. So estrogens are converted from testosterone, and DHEA are androgens through aromatization. And aromatization is a process of conversion through an enzyme from the androgens to estrogen. That's an important thing to understand because in postmenopause, we rely on our testosterone conversion to estrogen to give us the levels of estrogen that we have in menopause. So estrogen, we have three primary estrogens. We have estrone or E1. This is our most abundant hormone in menopause. We have estradiol or E2. This is the most potent hormone in cycling females. And then we have estriol or E3, which is most impactful in pregnancy. So what does estrogen do? Really, estrogen is proliferative, right? It helps to grow things. It helps to grow breast tissue, uterine tissue, ovarian tissue, or follicles, like the little eggs that we pop out of the ovaries. It also helps to support bone health. It is responsible for hair and breast growth in puberty. It is also responsible for regulating our menstrual cycle. Without estrogen, we can't have a menstrual cycle. So estrogen is very influential for the menstrual cycle. What are the benefits of estrogen? I feel like estrogen gets a bad rap. We want to make sure that we understand why estrogen is here because she is important. So benefits of estrogen in females are menstrual timing and regulation, sexual desire and libido, cholesterol metabolism, bone health, brain health, so think memory and mood, skin and blood vessels. Think about like how elastic and stretchy your skin is, right? When we lose estrogen, we think of like wrinkles on the face. When we lose estrogen, that means our skin is not as stretchy, right? It's the same thing with your blood vessels. So that also ties into cardiovascular health. We want to make sure that our blood vessels stay nice and supple so they can pump our blood. When they lose that elasticity, it can create issues for our cardiovascular health. Metabolic health. So estrogen or estradiol is a very potent cellular signaling hormone to help with metabolism. E3 also is an interesting part of our estrogen evaluation. Some consider estriol to be anti-inflammatory, and it can be utilized in high doses for autoimmune conditions. So that's an interesting part of estriol. Our next hormone, progesterone, is dependent on estrogen. So we kind of talked about this, but estrogen signals progesterone to increase and prepare the endometrium for implantation after ovulation. Progesterone is meant to balance estrogen in our luteal phase of the cycle, or the second part of our menstrual cycle. And progesterone is made from the corpus luteum, which is left over from the follicle created from ovulation. So once that egg bursts out, we have this remnant corpus luteum, and that's where we get progesterone production from. Benefits of progesterone in the postmenopausal female. It can improve mood, it can improve sleep, it can help reduce hot flashes, and it can influence bone mineral density. Next on the list, we have testosterone. So benefits of testosterone in females help our muscle mass. It supports joint lubrication, sense of well-being. So, you know, how we feel mentally, right? Like what we're able to do, like when we think about ourselves, how we feel, that's our sense of well-being. Drive. And when I look at drive and motivation, that's not just about libido drive, like sex drive. It's also about mental drive, like your mental capacity to have that mental motivation to do things in the day. It can also influence bone health as well as brain health. It influences your focus and spatial processing. Next is our DHEA. So DHEA is a complicated hormone and still needs more research. It does get to play in both the sex hormone realm as well as the adrenal realm. It is a precursor hormone to both testosterone and then to estrogen. We know that DHEA helps to balance the effects of cortisol. It also supports bone health and can influence mood and sense of well-being. It is also correlated to immune and disease states. So when we're looking at perimenopause and menopause, we want to kind of go through the symptoms and process of perimenopause to menopause. So the first part of discussion that I would like to address is the initial loss of progesterone. So when our estrogen starts to have that variability, we start to lose out on that progesterone, and that loss of progesterone can happen usually anywhere between 5 and 10 years prior to that significant loss of estrogen. So we're getting that significant variability, but we start to lose more progesterone much sooner than we lose our estrogen. Loss of progesterone can show up as initiation of vasomotor symptoms. So when we think of vasomotor symptoms, of course, in the medical world, we have to have a totally different dictionary, right? So we have to learn a new language. Vasomotor symptoms include hot flashes and night sweats. We can also see poor sleep due to loss of GABA stimulation in the brain from progesterone, poor mood due to loss of GABA, right? So when we think of GABA, GABA is the one that helps to calm things, right? It can help with sleep. It can help reduce anxiety. So that's where it can affect your mood. Brain fog. And then when we look at the poor mood due to fluctuations between progesterone and estrogen, right? When we have variability in estrogen to progesterone, we can have relative progesterone deficiency, and that can also influence mood variability in general. Next would be variable levels of estrogen. So when we're looking at this process of that perimenopause to menopause, initial loss of progesterone, variable levels of estrogen. So this looks like you can have too low levels of estrogen. And when we have some of these symptoms, we're looking at irregular cycles, hot flashes, night sweats, mood changes, changes in focus, muscle and joint pain, headaches, loss of hair, migraines, loss of skin elasticity, which also looks at loss of blood vessel contractility, changes in cholesterol levels. So cholesterol is that precursor to all of our steroid hormones, right? When we don't need as much estrogen and progesterone, our cholesterol doesn't need to rally that up to convert into estrogen and progesterone. So instead of converting it, it goes back into cholesterol. So this is where you can start to see some of those changes in cholesterol levels. We have loss of bone density. So estrogen is a powerful force to help to maintain bone density. You have a change in body mass distribution, right? So estrogen is really nice at helping us keep that hourglass figure. When we start to lose estrogen, we can call it more of a blob figure versus an hourglass figure. Changes in sleep, changes in energy, so increased fatigue, changes in bowels, dizziness, and changes in urination or bladder symptoms. So think UTI type symptoms, but you don't necessarily have a UTI. And a lot of times this has to do with the vaginal pH because of your estrogen and progesterone levels. On this flip side, right, we swing the pendulum to the other side. We can have estrogen levels that are too high. This is where we look at irregular cycles, hot flashes, night sweats, irritability, breast tenderness or enlargement, and increased blood volume. So fluctuations of estrogen occur due to inconsistent signaling of FSH from the brain, right? Like the ovaries are signaling back to the brain. The brain is trying to signal to the ovaries that like, hey, we need more estrogen, or we have enough estrogen, we don't need as much. So you get this kind of faltering and like tripping over, trying to create that consistent signal. But that's where FSH starts to become inconsistent, and we start to see those FSH levels rise. Estrogen may appear dominant due to insufficient progesterone to balance your estrogen. So next on the list, after we've had all that crazy variability of estrogen, are the low levels of estrogen. And this is where we start to see true low estrogen symptoms. So this isn't necessarily a symptom per se. Sometimes people will notate this as bone pain, but some people may not even like put this on the radar as a symptom, but low bone mineral density. So think osteopenia, osteoporosis, or could be reported as bone pain. Your vasomotor symptoms, so those hot flashes, night sweats, the burning from the inside. This is most likely contributing to poor sleep and poor quality of life when we look at vasomotor symptoms and how this can affect you on a day-to-day basis. We also have vulvovaginal atrophy, or VVA. So this is vaginal dryness, can show up as pain or discomfort with intimacy. Even wiping, urination, like it might burn to pee, and even when you go to wipe it, might be uncomfortable. Even just sitting can be uncomfortable. Swimming, hot tubs, exercise can become a problem. The other thing that happens with vulvovaginal atrophy is the labia shrink, right? We don't have all of that estrogen to help plump those vaginal cells and plump those labial cells. So the vaginal cells become taut and tender, and that's why it can be painful, right? We don't have the 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 juiciness that gives those cells the we like them to be nice and juicy because then they're able to stretch, they're able to feel more comfortable with any kind of activity. When they don't have that estrogen support to have that moisture, they become taut and dry, and that's where it can be more painful. Mood changes. So generally we see this as low mood, possibly depression symptoms, anxiety, brain fog, confusion, more confusion of like, wait, what was I doing? What was happening? But also that recall, right? Where it's like, man, I used to be able to remember this whole list of things, like either at work or with the family, but now you have to start writing things down and then like you forget where you put that list, right? Like those kinds of things with brain fog. Last on the list is our consequent drop of testosterone. So our drop in testosterone levels means we can see a lowered muscle mass, lowered sense of well-being, a joint pain and muscle pain, increased fatigue, decreased motivation. And that motivation is that like drive, right? So not just libido, but also brain motivation. By menopause, women lose up to 3/4 of their peak level of testosterone. Though research shows that by 65 to 70 years old, your testosterone levels may return to similar levels as when they were younger. But what happens in between that time, right? Like that perimenopausal period, that drop in estrogen. So there's this black hole area where your testosterone just drops off. And so that can also be pretty significant when we're looking at symptoms. So menopause experience, and these are things that I have heard just from clinical practice, right? I can't enjoy intimacy anymore. My body has betrayed me. So there are a lot of feels that come with menopause. My body's betrayed me. It's not the same that it used to be. Why do I have acne? I thought I already did this in high school. Why do I get to do it again? I'm grieving the loss of my vitality, the loss of my youth, right? Like when we think about as females, when we were entering into that first puberty, and it was that, unknown of like, what is a period like? What is that going to feel like? What does that mean? Like all of those questions, right? Some people were really excited about it. Some people were really scared and just didn't know what to expect. Some people didn't get talked to about puberty and starting your period. And I feel like it's the same thing, right? We come full circle when it comes to perimenopause and menopause. And it can be a very scary time because we don't know what's happening to our body. But it's also that acknowledgement of what does that mean for you? Does that mean vitality? Does that mean youth? Or some people look at it as like, thank goodness, right? Like, hallelujah, the doors are open. I don't have to worry about this anymore. So there are lots of feelings that come with that. Why am I gaining weight? There is a lot, there's a big portion of our population that ends up gaining weight with menopause. My body's in pain. I can't do what I used to be able to do because of joint pain and muscle pain. I am so tired. I can't sleep, right? Like sleep is affected. My mood's all over the place. I'm crying, laughing, and irritable all at the same time. I feel like I don't know my body anymore. And also in that perimenopausal stage, why am I bleeding through my clothes, right? Like you and your cycle kind of got used to each other. You kind of knew what to expect. And then all of a sudden she changes again. And it is so hot in here. How many people have said that? So many different experiences that can happen. And like everything on the screen can also happen within a 10-minute period, right? So just think about that. Like that is a lot to deal with just on a daily basis, just the changes and like what your brain is going through and like what is happening to my body and how can I feel about that. So it's that idea of second puberty and variable levels of estrogen that lead us to all of those fun symptoms. And as we discussed, that loss of progesterone occurs around 5 to 10 years prior to our loss of estrogen. If any of you are like me, I am that sweet little lady there. Hot flashes were not a friend to me. So let's talk about menopause interventions. And for the purpose of today, we are going to talk more about HRT or hormone replacement therapy, but there are other options when we look at support for hormone changes, right? We have hormone therapy, there's synthetic and bioidentical. We have nutritional therapy, so protein intake, looking at macros, feeding adjustments, intermittent fasting. There are all sorts of nutritional modalities that can help to support you through the change. When we look at how our bodies change, even when we're cycling, we want to take that into consideration when we are going into perimenopause and menopause as well. Supplementation to include amino acids, creatine, different herbs and vitamins, nutrients. There are a whole host of herbs and amino acids that can also support adjusting or trying to smooth that transition from perimenopause to menopause. And lifestyle adjustment. So exercise, moving your body is a must, right? It's definitely something to consider when looking at supporting your body or optimizing your body through the change. And sleep patterns. So I would love to say that sleep is a priority and important. I know it becomes really frustrating when you're like, yeah, it's great, Debbie, except I have hot flashes all night and I can't sleep, and then you become more irritable. So it can be a bigger discussion than just be like, well, sleep better. But that's the discussion of what are the things that we can do to help support sleep there. So when we look at options for hormone therapy replacement, or HRT, we have synthetic HRT and we have bioidentical HRT. So synthetic hormones are hormone compounds that act on our hormone receptors, but may also act on other receptors. So they're not just honed in on, let's say, the estrogen receptor. They can affect other receptors in the body. Examples of synthetic hormones include something like Premarin. Bioidentical HRT, or BHRT. These hormones are made from plants and mimic our own hormones' influence on the hormone receptors. So when our progesterone receptor sees a synthetic progesterone, it will act on that progesterone receptor, but you may have other reactions that occur with that. When we're looking at bioidentical progesterone, we have our little progesterone receptor here. We have a bioidentical progesterone that comes in, and it acts appropriately on that progesterone receptor the way that our own progesterone would act on our progesterone receptor. And when we look at hormone replacement therapy, these are generally our options for sex hormones, right? Estrogen replacement therapy, or ERT, progesterone replacement therapy, and testosterone replacement therapy, so TTH. Let's look at estrogen replacement therapy. So we have 3 primary estrogens that we talked about, and we can outline 3 possible options for estrogen therapy. So when we're looking at estrogen therapy, we can supplement with estradiol. This is the most common supplemented estrogen, or E2. We can supplement with estriol, the next most common, or E3. And we can also supplement with estrone. That is the least common, but that is our E1. One of the things that I wanted to put on here is a bi-est formula can also be an option. This usually contains a combination of that E3, estriol, and E2, or estradiol. The ratios that I put here, these are the more commonly found, are an 80-20 ratio, where we have 80% E3, 20% E2, or a 50-50 ratio, so 50% E3 and 50% E2. So those are most commonly used when it comes to a combination for bi-est. A tri-est formula is also available, where you use all 3, the E1, E2, and E3, but it is much less common. And in general, the bi-est formulas or the tri-est formulas are usually a cream. So when we look at estrogen replacement therapy, these are generally the more common options or availability. So we have topical estrogens in a cream form, a gel form, or a patch form. We have oral estrogens. This can come in pills. They can also come as troches, usually seen to be used sublingually, which is a little bit different than oral, but you can have some oral effect with sublingual administration of hormones. We have vaginal options, so vaginal creams, gels, troches, suppositories. And then we also have pellets. I know this is probably a little bit newer on the market. It's more of like an implant, like you don't inject it yourself, but it gets implanted through a professional. And you don't have to, when you get a pellet inserted, there's a usual time frame. It can be anywhere from 6 weeks to 3 months to 6 months, depending on you and your provider. So I do want to put on the radar, there is risk when we're talking about oral estrogen. So when we're talking about oral estrogen, because they are swallowed, they're then processed through the liver. The liver does its job, but in that it activates clotting factors in response to estrogen taken orally. Once clotting factors are activated, these can increase the risk for blood clots. And this is why you can see, like when you're looking at oral birth control, right? So when you're thinking of just general birth control that has a synthetic estrogen in there, it will say, right, like risk for clotting or stroke because it's an oral estrogen. That same risk goes through into menopausal HRT. So if we're talking about oral estrogen, we want to remember that. And oral estrogen is usually not the preferred method for estrogen replacement therapy. So then we have our progesterone. So not all progestins are created equal. There is a big difference between progesterone and progestin. So progestin ends up being the umbrella for all progesterones. But we want to remember that progestin is a synthetic progesterone and has a different effect on receptors than progesterone. So progesterone is the natural form of progesterone, and that is going to be what we're talking about today, not progestin. We'll be talking about progesterone, but please remember that when you're talking about progestin, make sure you know what progestin you're talking about or which progestin you are taking. My preference is to use progesterone. So when we look at progesterone, we have some other options. We have oral progesterone, commercially available. It's called Permetrium, but you can also get oral micronized progesterone through compounding pharmacies, OMP. You can also get sublingual progesterone. I put this again under oral because you can get some of that oral effect when you use a sublingual form of progesterone. There is topical progesterone, cream, gels, oils. There's a vaginal progesterone, vaginal micronized progesterone, also known as VMP. You can see vaginal applications in a cream, a gel, a suppository. Pellets are also available for progesterone. They're not very common. Injections are also an option, but these are more common with fertility treatments. So the more commonly associated progesterone supplements are either oral, topical, or vaginal. And then we have testosterone. So generally, our most common form of testosterone supplementation is topically in a cream or a gel. You can do vaginal in a cream, a suppository, or a troche. They do also have testosterone pellets, similar to estrogen, right? Like you have a professional insert the pellet, and it usually lasts for a certain time frame, depending on what the dose is and what you and your provider discuss. They do have injections for testosterone. They also have oral testosterone. I generally see this as a troche. This is the least common, and it has a similar risk profile as oral estrogen. So when we're looking at testosterone, I would say the most common is topical. We do see a lot of vaginal and pellet therapy as well. So when it comes to FDA approved hormones, I wanted to put these on here so you could kind of get an idea of what the FDA has approved for estradiol. These are the gels that have been approved. This also lets us know like what the doses are and what the relief is when we're looking at using an estradiol gel, right? So a lot of the things that we are trying to target when we're looking at estrogen supplementation, for example, is reducing vasomotor symptoms, those hot flashes and night sweats, supporting bone mineral density, reducing vulvovaginal atrophy, so that vaginal dryness. And so there's a pretty decent list of FDA-approved estradiol gels. We also have some FDA-approved patches, and I would say patches are probably the most common that I have seen. I think it depends on where you are in the country, what you have access to, and what your either practice has been, like what your scope of practice has been, what you've been able to learn as a provider. But these are your E2 patches approved through the FDA. And again, this also looks at, when we're looking at these estradiol patches, what are the goals for this, right? Can they, at their doses, reduce vasomotor symptoms? Can they support bone mineral density? Can they reduce vulvovaginal atrophy? Like those are the big things that we look at. And these are the things that the FDA is also looking at and why they would be approved at these doses. We want to make sure that any kind of hormone therapy we do is done appropriately, safely, and effectively, right? Like we want to make sure it's having the appropriate effect. So the other part of that are compounded hormones. So compounded hormones are not FDA approved at this time. Though many compounding pharmacies service a need for compounded medications, including bioidentical hormone replacement, due to the need for individualized medicine and consideration of patient-mediated care. So there are FDA-approved bioidentical hormones as listed in the previous slides, just not compounded. So how do we test these levels? Now, we can do testing in urine, we can do testing in serum, which is blood, and we can do testing in saliva. Now, obviously, I'm a little bit biased. I'm going to prefer the Dutch test. And in this, not only do we get to see, like in our little graphic here, we can see we get the estrogen with our estrogen metabolites, our progesterone with their metabolites, testosterone with the androgen metabolites. We also get the full picture of our cortisol and HPA function. We get to understand some of the oxidative stress and melatonin. So this is looking at all of those things like energy, sleep, stress, as well as that sex hormone evaluation. So when it comes to hormone monitoring options, we have this monitoring BHRT with lab testing. So this goes through, right? Like if you have oral progesterone, what are the good options for us? If we have estradiol as a patch, what are the good options for us? What about an estradiol cream or gel? What are the testing options and what are the benefits or what are the caveats to testing? So this, when we look through here, we can see that, oral progesterone can be useful in dried urine testing or Dutch testing because we want to be able to look at how the body breaks down progesterone, right? Like, are we more of an alpha or beta metabolizer? So it's looking at metabolite preferences to support some of that progesterone dosing. We also see that the transdermal applications of estrogen are a good, we can use Dutch as a good way to evaluate how that looks with supplementation. Same thing for vaginal estrogen and testosterone. Vaginal progesterone is, I would say, Dutch is not a great option for that. And then for transdermal testosterone and testosterone injections and pellets. So we can get decent information with testosterone as long as we are using it as a comparison or correlating it with serum. I know it seems kind of silly to say, well, why would I do one test and have to do another test? But they complement each other well and can offer greater insight into what those levels look like and how the body is utilizing that testosterone therapy. So is there research for dried urine? The short answer is yes. So we have a lot of published research. If you go to DutchTest.com and hit some of the research tabs in there, you can see these studies that we have. The bigger things that I want to highlight here are, like the burden of urine collection can be reduced using collection of the 4-spot dried urine, meaning instead of carrying around a jug of urine, you can test on urine papers 4 to 5 times throughout the day. And we have a good evaluation of what those hormones can look like. The other part of that is that dried urine for estradiol and progesterone is a good surrogate for serum testing. We also have some other posters that walk through some of the testing that we've done with estradiol gel therapy and validation. Monitoring estradiol patch therapy, validating through dried urine, and then looking at the comparison between patches, gels, and creams. So this is some really good information when you want to dive into the research. We're not going to fully dive into that, but we do have research to support that information. So we also want to take into consideration the goal of hormone therapy, right? Like, why? Why are we wanting to do this? So generally, we want to reduce the symptoms and risks, including that vulvovaginal atrophy, our vasomotor symptoms, so hot flashes and night sweats. We want to help to improve our bone mineral density. When we think of bone mineral density and bone loss, the risks of osteopenia and osteoporosis are fractures, right? We want to be able to have strong bones so we have reduced fractures. The better we can move our body, the healthier our quality of life is. And we look at extending our quality of life. Reduction of cardiovascular disease risk. So remember that heart, our cholesterol metabolism and cardiovascular health, and then in general, improved quality of life. I've had women, back in the dark ages, we were following the WHI advice where you shouldn't be on estrogens and you shouldn't be on hormones because they were dangerous. There were women that had luckily were put on hormone replacement therapy, and they threatened to hurt me if I wanted to take them off of it, according to research. Luckily, that research has changed, but that is how significant the quality of life can change when we look at introducing hormone therapy. So our goal of hormone testing is to understand baseline. So this is important to evaluate our levels of estrogen, progesterone, testosterone, DHEA, cortisol, melatonin. Understand metabolomics. So we want to understand how the hormones are being processed in the body, how they're being metabolized. And it's great to review our HPA axis influence on sex hormones. So that's essentially how is stress affecting our sex hormones. And we also want to use it to understand follow-up, right? We get our baseline, we look at this and we're like, great, okay, let's look at these different options, whether it's herbal, bioidentical, HRT. We want to be able to evaluate the changes in our hormone levels with supplementation. We want to be informed on metabolite preferences to optimize supplementation, right? Our metabolites can make a huge difference in how safe our body is processing those hormones. So the goal of hormone testing and using Dutch tests, so dried urine, we want to be able to utilize the research to ensure dosing of HRT is sufficient and effective to reduce the symptoms and risk. So research finds that serum or urine levels just outside of the postmenopausal range and into the lower part of the premenopausal range, or that luteal range, cycling range, may be optimal targets for both our estradiol patches and gels. And the reason why that is a goal is because that's where we find the research says this is where your bones can be supported. So our goal range for estradiol in serum is between 20 and 60. And then on the Dutch test is between 0.7 to 1.8. And that's going to get us that good bone support. On this slide, we're looking at the, serum levels correlate to clinical improvements for both estradiol patches and gels as it relates to all of the symptoms that we just talked about. Also changes in our FSH, our cholesterol, sex hormone binding globulin, and the endometrium, so your uterus. Urine levels generally parallel serum levels and clinical outcomes with transdermal estradiol gels. So that research that we talked about, you can really dig into that with this information, but that's the biggest highlight that I want to look at here, right? The urine levels generally parallel those serum levels. Our takeaways are that dried urine testing may be used as a surrogate for serum testing according to peer-reviewed studies for estradiol transdermally. Serum testing has been the gold standard against all other methods in general. In non-supplemented data, so nobody doing hormone therapy, serum and dried urine correlate well. In estradiol patch and gel studies, dried urine parallels those serum values. So with that, we can understand that we can look at Dutch testing and know that if we get these levels, it will be comparable to doing the testing in serum. Now, a quick note about HRT and best practices. So Dr. Doreen Saltiel completed a webinar that walks through all of this information in detail. It's invaluable information. One of the things that I want to agree on moving forward is that with any sort of estradiol supplementation, oral micronized progesterone or vaginal micronized progesterone should be considered according to the research to ensure endometrial protection. So that is making sure that we don't have endometrial hyperplasia or that our uterus is not doing things that we're worried about. This looks like oral micronized progesterone of 200 milligrams or vaginal micronized progesterone ranging between 50 and 100 milligrams. The other agreement is that oral estrogens and oral testosterone come with significant risk, and it is not a preferred method of supplementation. So one of the things we want to understand is how to read and understand the numbers. So there's something that we have here at the Dutch test called Mind the Gap. No, we are not in London, though that would be fun. But this represents the space between that postmenopausal range and the premenopausal range. So my little cursor here, this purple blue box is the postmenopausal range. See how tiny that is in comparison to the premenopausal range, which is huge, right? Like it goes from a low limit to a high limit. Postmenopausally, we shouldn't be having significant variability in our estrogen, right? We already had that variability when we were cycling and, floundering into menopause. Postmenopausal ranges should be pretty static and they should be within a small amount. The range should be a small range. So the postmenopausal range and the premenopausal range should not overlap. There should be a distinct difference between postmenopausal and premenopausal ranges. The other part of this is when we're looking at, like on this graph, for example, we have urinary estradiol concentration on the vertical side. On the horizontal side, we have our transdermal estradiol patch. What we see is we start out at a postmenopausal level, and with supplementation, we go through that gap, right, and then into some of those luteal ranges. We can see on this graph the distinct difference between the postmenopausal range, the application of the estradiol patch, and the change from postmenopausal range into that premenopausal or luteal range. So again, mind the gap. So here's where we look at the value of testing, right? This is a baseline test for a 43-year-old female with irregular cycles. So we would call her perimenopausal. What we are evaluating: how variable are estrogen levels? What is the estrogen level relative to progesterone? What are the androgen levels? And how is HPA axis function, right? We can see this on a Dutch Complete or a Dutch Plus. Now, this data at baseline offers good information to understand the hormone levels as a one-day check-in, and we can see she is estrogen dominant relative to low progesterone levels. She has low to normal range testosterone, and her DHEA is within range for her age, and she has low cortisol output or low HPA function. So this is a nice way to understand a baseline of where she's at with those hormones in relationship to each other. Now, in the value of testing, this patient also did a cycle mapping test. So the addition of a cycle map test for this patient expands on the variability of her estrogen in this stage of menopause. We can see she has aberrant estrogen signaling, right? Like she tries and fails, tries, right? Like her poor little body is trying to get that estrogen peak in there so she can achieve ovulation, but she failed. And because of that, she has no ovulation, therefore she has no progesterone. And this is where we talk about progesterone relies on estrogen, right? Like if estrogen can't get the job done, progesterone can't step in to finish the job. Now, is it overkill to do a cycle mapping test for a perimenopausal female? It depends on the patient. In this case, you could go either way, right? Her cycle map confirms what her Dutch Complete showed, but the Dutch Complete offered valuable insight on its own as well. You don't have to do a cycle map test for a perimenopausal patient. I would say this would be something to consider if you have significant variabilities in cycles, and it's really hard to kind of just do a random test. Usually once it's been like 6 months since you've had a cycle, you can just do a random test of a Dutch Complete or a Dutch Plus, but it depends on the patient. So that's where we want to look at individualized care and deciding if the cycle map would be worth it. Generally, depending on where you're at in that perimenopause to menopause path, I would say not to look at a cycle map unless, again, that question comes up with regard to how confusing it would be to figure out timing. So this is where we're going to step into some case studies. So PMP means postmenopausal female with estradiol and progesterone hormone replacement therapy. So for case study examples of HRT on Dutch testing, right? Like this is what we want to be able to see. So this is postmenopausal female. Her uterus is intact. She's 63 years old. She's supplementing with progesterone at 200 milligrams orally. Estradiol transdermal patch, 0.075 milligrams. So what we can glean from this is that her E2, which is what she's supplementing with, right, is at 1.7. We know that our goal, at least for bone health, and when we're looking at that in comparison to cardiovascular health and overall quality of life, reducing vulvovaginal atrophy, reducing those vasomotor symptoms, our goal is to be between 0.7 and 1.8. She is at 1.7. She gets a gold star, right? So her estradiol dose looks appropriate for bone protection. Her estrogen metabolism shows that her 4-OH levels are slightly elevated, and that's, in comparison to her 16-OH and her 2-OH. We see that research supports 200 milligrams of progesterone for endometrial protection. That is what she is taking. Now, we can see this on the Dutch test, right? We do adjust for oral ranges of progesterone. But the other thing that we want to look at here is that breakdown of her metabolites. We have an alpha pregnenolone and a beta pregnenolone for those progesterones. The alpha pregnenolone is the one that can really support the GABA response in the brain, especially with oral or sublingual progesterone. The beta does not have that same crossing of the blood-brain barrier. And what we can see for her is she has a much bigger preference for that beta metabolite, which means she may be getting some of the benefit for GABA support with the dose of progesterone that she's getting, but because she's such a beta metabolizer, she may actually require a little bit higher dose of progesterone to get that full GABA effect for crossing that blood-brain barrier. At minimum, she is getting that 200 milligrams of the progesterone for her endometrial protection, which is great. So again, we can see the value of the progesterone metabolites here given her beta pregnenolone preference. And that could also influence if you wanted to adjust the dose of her progesterone here. So same patient, we also see her androgens. So her testosterone and DHEA, or those androgens, are low normal for her age range. She is a beta metabolizer. So we can see progesterone has an alpha beta preference, where we can look at the alpha versus beta. Our androgens also have that alpha versus beta. So hopefully, most of the time, they correlate with each other. Sometimes they don't, but on her, she does. So her beta metabolism also shows up in her androgens. When we look at the difference between alpha and beta, right, like alpha is the more potent form of androgen, beta is the less potent form of androgen. So that tells us she's got low to low normal levels of androgens, and they're going down the least potent pathway. So her androgen metabolites are low normal. And in this, we can see she's got great estrogen support. She probably needs a little bit of support for estrogen metabolism. Her progesterone is protected for endometrium, but her testosterone could probably use a little bit more support. I highlighted the page 2 androgens and metabolites discussion here because we get to see a little bit more. We see her testosterone level here, but we also get to see her 5-alpha DHT, her 5-alpha and beta androstenediol, and her epitestosterone. It's important to look at these. So we're not just honing in on the testosterone. Our 5-alpha DHT is the more potent androgen. It's 3 to 5 times more potent than testosterone. But the 5-alpha androstenediol also is more reflective of tissue levels of testosterone. So even though her testosterone shows to be below range, her 5-alpha androstenediol is technically within range. She's on the low end. But that lends us to understand what is happening at the tissue level for her testosterone and how that may feel for her. So our next review is a postmenopausal female with biased transdermally and progesterone HRT. So biased, remember, is that combination of E3 and E2. So when we look at this patient, she's postmenopausal, uterus is intact, she's 76 years old. She is supplementing with bias as an E3, E2 topical and progesterone orally at 100 milligrams. So key points or takeaways from this are we can look at her progesterone metabolism here. We can see for her, she also has a beta preference, which means that alpha, or crossing the blood-brain barrier, may not be as potent for her. So she may not be getting that full alpha GABA benefit with her progesterone. It depends on how sensitive she is to that GABA effect. The other part that we see here is her estradiol is at 0.6. Now remember, our goal for bone health and the hopeful reduction in symptoms is to be at 0.7 to 1.8. So she's just below that optimal range. Her E3 is just below luteal range, so she's above that postmenopausal range there. That's going to be part of that E3 that she's getting in that topical estrogen. And her estrogen metabolites show us that she is getting a lot of 4-hydroxy. So the 4-hydroxy pathway is the bad pathway, right? Like we're going to make some, but depending on the person, we want to see how well their body is breaking down their estrogen. Are they sending it down the good pathway that's going to get broken down and not be dangerous? Or is it going down the pathway that's going to be more dangerous? So she's getting some estradiol supplementation. She's getting the E3 supplementation, but she also has a high 4OH. That could be problematic. Lucky for her, she's got a good methylation, but we want to, consider what her estrogen metabolism is here with supplementation. Now, things that I would point out are that she's not getting effective estradiol dosing for research-supported bone health, and she's not achieving appropriate progesterone dose for endometrial protection. So she still has a uterus. Now, granted, she is 76, but when we look at research, I know a lot of times people as providers, when we are testing and we are supplementing, we want to know, right? Like, is this the right dose? And we look at testing to help us evaluate that and understand what we need to do. What we need to understand about progesterone is the research supports 200 milligrams of oral progesterone is what protects the endometrium, because this does not tell us the tissue levels of progesterone. So even if the patient says, oh, my sleep is better since starting progesterone, or my hot flashes are less since starting progesterone, she's still not getting that endometrial protection. So that's something to consider. The other caveat that I actually didn't put in some notes here is that when we're looking at a bias, we have E2, E3. We don't know for her if she's at the 80-20 or 50-50 or what her ratios are. But what we can sometimes see is that estriol can compete for receptor activity with estradiol. And for some people, this may mean that the E3 kind of robs the E2 of being able to do its job. So that's also something else to consider when you're looking at a bias formulation here. It may be just a simple adjustment of her estradiol, but it may also be adjusting that E3 for her as well. For her androgens, we have robust testosterone. We have low normal DHEA values in general, but she does have an above range 5-alpha and beta androstenediol. So when we look at like tissue levels for her androgens, that actually looks fairly robust. Now, she is also a beta metabolizer for her androgens, so she is sending those androgens down the least or the lesser potent pathway. So she, like, this may all kind of come out in the wash that her testosterone feels well for her. But this is where it's important to look at not just the testosterone, we also want to look at those testosterone metabolites on page 2. Our next case is a postmenopausal female with bias. We don't know how she's taking it, if it's a cream, if it's a gel, if it's oral, we don't know, and progesterone replacement therapy. So postmenopausal female, she has no ovaries, unsure if she has a uterus. She just says she didn't have ovaries. She is also 71 years old. She is supplementing a biased 2 milligram. Again, unsure of the route of administration. It's probably transdermal. And she has an oral progesterone supplementation of 200 milligrams. And notice the thumbs up there. I'm happy with that because that helps to ensure she has endometrial protection, right? Key points of this test show her estradiol. She's at 1.7. Remember, our goal is to be 0.7 to 1.8, and she slides right in there. So she's getting good bone health protection. And the hope is that she's also achieving, improved, reduced hot flashes and night sweats, reduced vulvovaginal symptoms, and her quality of life is just really better. We can evaluate her progesterone metabolite preference here. She is also a beta metabolizer, not as strong in the alpha metabolism. Her estrogen metabolism here, her phase 1 looks great when we look at the differences between her 16,4 and 2-OH. But she is a poor methylator. Her phase 2 is lower poor. So that tells me she's able to get her estrogens through phase 1, but she kind of stops up at phase 2 clearance of methylation. So that may be something to consider when we're looking at supporting optimal estrogen metabolism. So I know we only have a couple minutes left. We have our postmenopausal female. This one has an estradiol pellet as well as a testosterone pellet. So this 53-year-old female, she is postmenopausal, so she no longer has a cycle. She's supplementing with an estradiol pellet, a testosterone pellet. She also has oral progesterone on board at 100 milligrams. Now, when we're looking at pellet therapy and testing, we generally recommend testing like in the middle of the timing. So if this person is on a 3-month schedule for her estrogen and testosterone pellet, we would want to check in. So 3 months is 12 weeks. We want to cut that in half, look at about a 6-week timing to do the testing to understand what that looks like for supplementation. Now, if you wanted to test sooner for a loading dose, you would want to do it closer to when she had the pellet inserted. If you wanted to do it at a trough level, you want to look at about 12 weeks so you can see the lowest level. We're usually looking for the average of how those pellets are affecting this female. What we can see is that her estradiol is at 1.3. She is within that goal of 0.7 to 1.8, so she's getting that good bone protection. Her testosterone is at 18.3. Usually when we see higher testosterone, we know that they're likely on a testosterone pellet. Her progesterone, so again, we want to look at those progesterone metabolites. Beta preference, so again, depending on how she is feeling, she may need more to get that true alpha benefit or that GABA benefit. But we also know that progesterone is what? We want it to be at 200 milligrams to protect the endometrium, right? So that gives us a good idea of what that looks like here for her progesterone. We also see in her estrogen metabolism that her 4-OH is high, and it is also high relative to her 16 and her 2-OH. So we want to evaluate that with her estrogen metabolism, being able to support healthier estrogen metabolism there. She does have good methylation, so her phase 2 methylation looks good. Here are her androgens. This is going to be much more, I don't want to say relevant. This is going to be relevant because of her testosterone pellet. So Her testosterone is above range, likely reflecting that testosterone pellet. It's not uncommon to see when we have higher levels of testosterone that our epi-testosterone ends up being below range. We usually see that when the testosterone is maybe a little bit higher than it needs to be. But we can also see the downstream effect when we look at those androgen metabolites, or 5-alpha DHT, her 5-alpha androstenediol, and her 5-beta androstenediol, right? Her 5-alpha androstenediol is within range, so we may actually be closer to when her pellet was inserted if she's not on the same time frame with her estrogen and her testosterone. So keeping that in mind, that she may or may not feel this effect of testosterone given where her metabolites are, but it's something to consider. She's still consistent with that beta metabolization, going down the lesser potent pathway. And one of the things that I wanted to point out here is it is preferable to utilize serum testing in combination with Dutch testing for testosterone. The Dutch test augments information with the metabolomics, right? So those are those androgen metabolites that we just looked at. And this is where we want to highlight here, right, on that testing matrix, transdermal or injections in pellets. It's helpful to look at the metabolomics, but we want to compare it or complement it with serum testing, as the Dutch test should not be used solely for testosterone replacement therapy. We want to do the complementary testing for that. Our last one is a postmenopausal female on just testosterone. So she's 63 years old. She's had a hysterectomy. She's doing transdermal or topical testosterone at 2.5 milligrams. Her testosterone is within range, but on the low end. Her DHEA and metabolites are either low end or below range. Her estradiol is within that postmenopausal range, not surprising given that she's not supplementing and she's postmenopausal. Her estrogen metabolism, she does have a higher 4-OH here. And then her progesterone is actually below that postmenopausal range. Again, not surprising given her cycle status. We do get to see key points of her androgens. She actually has an alpha preference, so she's going down the more potent pathway. Her 5-alpha androstenediol and 5-alpha DHT are within range. All of her other metabolites are low or below range. This would be a discussion of how she's feeling on this testosterone. So it may be well reflected on Dutch testing, but again, we want to correlate with serum values. We also want to look at our metabolites here, her 5-alpha DHT, that 5-alpha beta androstenediol, and how her symptoms have changed with testosterone supplementation. This is just a quick look at a non-cycling female with oral sublingual progesterone and a topical E3. So this is being able to see she's got just a 32 milligram topical progesterone. Here we can see that does put her alpha a little bit closer to that luteal range. She has that bioestrogen, which is an estriol cream. So we can see her E1 is on the low end of that postmenopausal range. Her E2 is actually below that postmenopausal range, but her E3 is significantly elevated. Not concerning because E3 is a weaker estrogen, but likely supportive of any concerns with vaginal dryness. The vaginal cells love estriol, and it looks like she's getting a good dose of that estriol. And overall, her estrogen metabolism looks good. So this is what you could see with a topical progesterone and E3 alone. Now, this one is just fun. This is an irregularly cycling female, and she's got all sorts of supplementation. Y'all, check this out. So she's 46. She's got irregular cycles. She has 5 milligrams of DHEA orally. She's got progesterone 200 milligrams orally. I'm a fan of that because why? It's protecting her endometrium. Now, she's also got biased. Now, this doesn't tell me what her bias looks like, right? So she's got biased with testosterone topically. She's got biased E2 topically and biased E3 topically. So she's got all sorts of bias happening. So she's got E2 and E3 as well as testosterone. Now, because she's having irregular cycles, she's probably still having some production of testosterone on her own, which is why she may be getting a little bit higher testosterone presentation here. We can also see with her DHA supplementation, for a 43-year-old, it may or may not be working to her advantage, but she has a lot of puzzle pieces in play here, are a lot of players moving on the board. But this is what we can see, right? Like that oral progesterone supplementation, we want to look at those metabolites. She's actually, I would say, decently balanced between her alpha and beta here. If you're not quite sure between her alpha and beta of her progesterone, you can always try to take a peek over at her androgens and see what her 5-alpha reductase activity is. It's not always 100% the same, but in general, we can assume that her alpha preference and her beta preference We can also see that her estrogen metabolism here, her phase 1 metabolites generally are good, except she's got a lot of 2OH. Why? Because she can't pop it out through phase 2 or her methylation being low there. So I know that puts us at time. And if you guys have any questions on these, I'm happy to answer them either through emails. We do have our Dr. Dutch at dutchtest.com as an option for follow-up, but we also have wonderful clinicians on staff ready to help all of this that I just batted up to send to them.
Yeah, thank you all for joining us today. Check your inboxes tomorrow for a link to the webinar recording and to download the slides. Additionally, please visit the Become a Provider tab at dutchtest.com to complete the steps to become a provider so you can gain access to all the educational resources we have available. And don't forget to check out the latest summer school episodes of the Dutch podcast. New episodes will be released each week leading up to the return of the Dutch podcast season 3 in September. Please rate, review, and subscribe to the Dutch podcast so you can start listening to season 3 the second that it drops. Thanks again for joining us and have a great day.
Thank you.